So thank you very, very much, everyone, for joining us this evening. We're delighted to have Professor Craig Shimasaki with us. Again, we've had him many times in the past. I'm sure you know him. I'll just introduce him briefly, and then he'll speak for about 45 minutes. And afterwards, we'll have some time for questions. And so we're very, very much looking forward to this. He's going to talk about, can infections trigger neuropsychiatric symptoms? Is there a connection between infections, the immune system, and the brain? He'll be presenting some case studies and talking about treatment resolution using the Autoimmune brain panel. So Professor Shimasaki is the president and CEO of Molecular Biosciences. He received his BS in biochemistry from the University of California, his PhD in molecular biology and biotechnology from the University of Tulsa, and his MBA from Northwestern University, Kellogg School of Business. He's an adjunct professor at the University of Oklahoma, and he's spent over 35 years working in the fields of molecular biology, viral pathogenesis, and infection-triggered autoimmune neuropsychiatric disorders. He has a long and very impressive biography. I won't go through it because it was on the website when you registered for this, but anything else we can either ask him about at the end, or he'll tell us as he presents. So I don't want to take away any time further from your presentation, Professor Shimasaki, so we very much look forward. Thank you.
Thank you, Jillian. And I trust you can see my slides and hear me okay?
Yes, yes.
All right. Well, it's always a delight to work with you guys at AONM. Appreciate all of the support and the work that you do to help patients and clinicians help take care of their patients. So today, I'd like to share with you and walk through some things that you may be familiar with, maybe not, but helping in understanding an area of medicine that I do believe is going to be one of the things that is going to help transform a lot of really chronic illnesses. And this is how infections, the immune system, inflammation are involved with developing chronic disorders. So let's get started here. And I do believe that there's chats for questions, or we'll have questions at the end. So again, there might be patients here or those that are just listening. This content is made for informational purposes only, and it's not intended to give medical or healthcare advice for any specific medical problem, but you should seek help from your medical or professional service qualified healthcare provider. So with that out of the way, what are we going to cover today? Well, I'd like to talk about the connection between chronic inflammation, immune dysfunction, and neuropsychiatric disorders. And then how is it that infections can trigger these neuropsychiatric disorders and or symptoms involved with them? And then why is it that only certain infections trigger these immune-mediated neuropsychiatric disorders? You might be familiar with PANDAS and PANS, or neurologic Lyme, or of course long COVID, everybody is. But these are medical models that we'll talk about. And then I'm going to talk about the autoimmune brain panel, which formerly we call the Cunningham panel, and these 5 biological targets and how these targets can aid in diagnosing and directing treatment towards the underlying root cause. And then we'll walk through a handful of case studies showing patients pre and post treatment and looking at their panel results, and then looking at what their treatments were given to these patients. And then we'll talk a little bit and summarize this in what maybe some takeaway messages are. So back to the issue, inflammation and immune dysfunction really are now showing to have a significant effect on chronic disorders, more than really we previously understood. And you can see diabetes, cancer, arthritis, cardiovascular, neurologic, autoimmune. And over 60 million individuals, at least in the United States, suffer from these chronic debilitating disorders, and millions really worldwide. And unfortunately, the belief is that there's no longer any hope for their full recovery because of these diagnoses or these conditions. So let me even start by explaining there's a difference between acute inflammation and chronic inflammation. Inflammation is not bad by itself. In fact, inflammation is an important aspect of our immune system that signals the rest of the immune cascade to be able to deal with whether it's infections or cancer or chronic disorder, anything that happens that would stimulate the immune system to be on alert, even healing your body. And there's a difference between acute inflammation and chronic inflammation. So chronic inflammation is where the immune system is not shut off and this inflammatory mechanism just continues to drive in the body. This does lead to autoimmune diseases, cancer, cardiovascular disorders, and now Alzheimer's. And we're going to talk about specifically how it can lead to psychiatric and behavioral disorders. So for those of you that follow the literature, all you have to do is look at a PubMed search, and you could see the exponential explosion of articles, peer-reviewed articles, on various topics like autoimmune encephalopathy, autoimmune encephalitis, neuroimmune disorders, this connection between neurology, the brain, and the immune system. And this also mirrors the growth in publications for the terms cancer immunotherapy maybe 25, 30 years ago. And now we know that immuno-oncology has a very significant place in medicine in treating the underlying root of various types of cancers rather than being called a cancer by the body part that it actually targets, because there can be different molecular mechanisms. So even evidence today is that Alzheimer's is an autoimmune disease. And you can see from here that more and more research and understanding is showing that there's an inflammatory component, and the belief that the beta amyloid is an immunopeptide. And there is maybe a decade or even longer progression of inflammation in the immune system involvement that leads to the ultimate diagnosis of Alzheimer's. So let's go back to the neurologic, psychiatric, and behavioral disorders. On this list here, you recognize many of these different disorders, and these are generally diagnosed and identified by clusters of symptoms defined by the DSM-5, and these are diagnosed, again, by clinical symptoms, not biology. So for instance, if an individual has motor or vocal tics for more than 12 months, that's the definition of Tourette syndrome. But it doesn't have anything to do with the underlying biology. And so patients then are typically treated for symptoms rather than trying to understand what the underlying root cause is. And as a result, anywhere from 20% to 60% of patients within these different categories become labeled as treatment resistant, meaning they don't respond to the standard psychiatric medications that are typically used for patients that would be diagnosed with these disorders. So we know that the standard of care for these is psychiatric drugs, and many patients do improve with these drugs because the underlying root is something that these drugs would treat. However, what we're talking now about is something that's immune mediated, and we'll talk a little bit more about that in just a second. But with these psychotropic drugs, there are deleterious side effects, course warnings, suicidal ideation, etc. That doesn't work, psychotherapy, and then institutionalization. So we need to be able to help those patients who are not necessarily improving with these standard of care treatments because their underlying root is a different etiology. So let's address the question, can infections trigger an autoimmune response that leads to neuropsychiatric disorders? And I'm not talking about a direct infection on the brain, which we think of like viral encephalitis or something like that. What we're talking about is an infection that triggers the immune system to do something to impact the brain. So here is a JAMA psychiatry study in 2019 of over 1 million patients who were followed from birth to age 18. And what they did in Denmark, they looked through the medical records and they chronicled and found that if a patient was hospitalized for a severe infection, that their risk of developing a mental disorder increased by more than 80% for schizophrenia, autism, OCD, ADD, ADHD, tic disorders, oppositional defiant disorders, and many, many more. And so the editors asked the question in a separate article, how could exposure to infections affect the brain mechanistically and give rise to mental disorders? What they said was circulating autoantibodies that enter the brain via compromised blood-brain barrier bind to neurotransmitter receptors, and that's a potential explanation. And this is the mechanism that has been proposed in pandas and other mental disorders. So if you're familiar with pandas, which is the pediatric autoimmune neuropsychiatric disorder associated with a strep infection, it is a medical model that we'll talk about here in just a second. So if we look at the biology behind what they were talking about, well, everybody gets infections. We all get infections. And our body, through the immune system, the innate and the adaptive immune system, and in this case, the adaptive immune system begins to produce antibodies that recognize these infectious organisms. However, in some individuals, and I say some individuals because there is a predisposition involved here, that the antibodies that they make and develop end up being made to the cross-reactive part of these infectious agents that look like these neurologic receptors through a process which is known as molecular mimicry. And as the JAMA Psychiatry article indicated, these antibodies cross the blood-brain barrier. They interfere with these neurologic receptors in a process we might think of as friendly fire. And a patient will then end up with eliciting these neuropsychiatric symptoms, which were described. They'll be placed on symptomatic treatments of which they become and diagnosed as treatment resistant because that's not the underlying root cause. Whereas the patients then are put on immune modulators or anti-infectives or anti-inflammatory agents end up with some really remarkable recoveries, which we'll talk about a few of these in our case studies. The other that the world has recognized, if there is any benefit to the understanding of long COVID, is that we then begin to have a greater understanding how a single infectious agent can trigger the immune system to be directed against the brain, the heart, the lungs, the blood vessels, and other organs, creating these chronic debilitating symptoms known as long COVID or PASC, post-acute sequelae of SARS-CoV-2. And they become chronically ill for long periods of time until they're adequately addressed. So if we think about the medical system and how the medical system is typically set up, is that specialization, although it's been amazing to see how important and advances have been made in specialties, it unintentionally makes it challenging to diagnose these types of patients that have complex immune-mediated disorders because psychiatry and psychology is separated from immunology and infectious disease and neurology. But we do know disease biology doesn't work that way. Infectious diseases do in fact affect psychiatry, psychology, and neurology and immunology. Therefore, in order to take an approach to help patients get well, we need these cross-disciplinary and collaborative medical care so that we can quickly diagnose and quickly administer the appropriate treatments to the patients that need them. Unfortunately, that's not universally happening right now. And so after having processed and tested over 16,000 patients, literally from over 50 countries and in the United States, this is what the typical patient journey looks like. they will have seen between 5 to 15 medical providers, maybe 3 to 7 years. We have some as long as 20, and spent literally thousands and thousands of dollars trying to find answers to help. And in fact, the burden of care costs are enormous. We did a burden of care study, which we're working to publish. And these are some of the comments that the individuals or the parents have written in of what they had to do financially in order to just really help stay on finding what the underlying root cause is and getting treatment so that they or their children can get well. So what is the answer? The answer is in precision medicine. And precision diagnostics can help us segment patients who present with similar symptoms. So what we want to be able to do is quickly segment patients into those that are immune mediated so they can be treated with an immune modulatory, anti-inflammatory, or other types of medications. And then the responsiveness to those who are not would be much, much greater and much, much faster. And so the goal of precision medicine is just what this looks like, finding the right treatment based on the underlying root and segmenting patients that have similar symptoms but underlying different etiologies. So let's move over to pandas and PANS. We're not really going to be talking a lot about pandas and PANS other than it's helpful to understand that this is a medical model for other immune-mediated neuropsychiatric disorders. And as you know, it's called PANDAS because of the acronym, Pediatric Autoimmune Neuropsychiatric Disorder associated with a strep infection. And we're really grateful for Dr. Sweeto, who identified this condition and been able to publish on it, and certainly lots and lots of other colleagues. So other publications have shown certain parts of the brain is where these autoantibodies attack, and it's called the basal ganglia. And the basal ganglia, as you can see here, you'll see some inflammatory conditions in populations of patients in the caudate, the putamen, the globus pallidus, but not the thalamus, because that's not part of the basal ganglia. And what we do know that the basal ganglia is responsible for is voluntary motor control, procedural learning, cognitive functions, emotional functions, and eye movement. And so if you take a look at the pandas and PANS symptoms, you can see anxiety, you could see loss of motor control, you could see cognitive dysfunction, emotional dysfunction, mydriasis, and you can see the correlation between antibodies or inflammation in that part of the brain and the types of symptoms that patients undergo. So let me just back away a little bit to talk about the nomenclature here. PANDAS, as you know, it mentioned, is pediatric pediatric autoimmune neuropsychiatric disorder associated with strep infection, but other microbes can trigger and do trigger a very similar syndrome. So they can't have PANDAS if it's not strep, and neither can it be called PANDAS if it's an environmental or other biological factors. So this is where the term PANS came. PANS removes streptococcal infection from this and refers to pediatric acute onset neuropsychiatric syndrome. But what happens if you're an adult? Well, you can't have PANDAS or PANS even if you have the same condition, the same symptoms, etc. So other terms like ANDL, which can stand for adult or autoimmune neuropsychiatric disorder associated with Lyme. Whereas all these other acronyms really are talking about a basal ganglia encephalitis or an autoimmune encephalopathy that's secondary to infection. Even an autoimmune encephalitis, although there's a connotation that an autoimmune encephalitis is related to a direct infection, but we're talking about really a disorder of the brain. But in general, we're really looking at all of these being an immune dysfunction that results in neuropsychiatric or behavioral symptoms that's triggered by an infection. So if we can get to that, we can then begin to identify the underlying treatments for this. So lo and behold, this is not new. Back in the 1600s, something called St. Vitus's dance, and which later became Sydenham chorea, Thomas Sydenham described what he called chorea minor. And that is where these abnormal movements, again, fine motor control, a loss of emotional control, were seen in these children who were infected with strep. And in 1894, Sir William Osler described what he called these bizarre and persivative behaviors in children with chorea minor and with symptoms of Sydenham chorea. Today, we know the causative agent of Sydenham chorea is group A strep, but we also know that acute rheumatic fever is, strep is the causative agent of that, but 30% of those with acute rheumatic fever end up developing antibodies against the basal ganglia, resulting in Sydenham chorea. So this is something that really is not new in medicine, but forgotten. And we understand that this has been around for a long time. So unfortunately, as we need to think a little bit broadly about this, this becomes a challenge for clinicians and patients that are looking at autoimmune neuropsychiatric disorders triggered by infections. So let's move over to another topic. Why do certain infections trigger these immune-mediated disorders? And what is it about these infections that do? Because they show up more frequently than other types of infections. And here's the bad actor list that typically you see associated with these infectious triggers associated with immune-mediated neuropsychiatric and behavioral disorders. Strep, obviously, pandas, influenza A, varicella, mycoplasma, Lyme, babesia, Bartonella, Coxsackie, and some others, including SARS-CoV-2 more recently. But what is it about these infections that make them more susceptible to patients who develop these disorders? Well, a term called molecular mimicry, which is why I named the company Molecular Biosciences, because it's based upon this mimicry in nature. And it's really a process that occurs when you have sequence similarities between a foreign, let's call it an infection, or yourself, let's call it a receptor, in the activation of these T and B cells. So if we think about the protein letter alphabet that only has 20 unique letters in the ones that we normally use, there's a few more, but for the purposes of today, the 20 letters of the alphabet, when you look at a sequence comparing it to the sequence of, let's say, streptococcus and maybe your heart valve or streptococcus in the basal ganglia, you're going to find a short run of letters that are going to be identical to each other just by sheer random chance. Well, our body usually will take care of that, and I won't go into that, but it's called self-tolerance, and the body in people that have good, healthy immune systems, or I should say immune systems without any susceptibility, will not make antibodies against those sections. So how does autoimmunity then occur where an antibody will recognize a bacteria or a virus and then recognize a neuron? So we think of these sequences as epitopes, which are just short letter runs of anywhere from 5 to 9 amino acids. And if your body makes an antibody to it, let's say in this case to a part of the bacteria, or let's say the M protein of streptococci, and the part of, let's say, dopamine receptor is identical to that, and it made it to that, then once that antibody is made and the B cell is producing antibodies, you're going to have an autoimmune condition in which you will get cross-reactive antibodies to these different targets. So this is why we call it molecular mimicry. And indeed, I won't go through the science, but in the group A carbohydrate and the M protein, there's molecular mimicry to parts of the heart valve, obviously the basal ganglia, which we get then rheumatic fever and Sydenham chorea, but then you see joint pain, arthralgia, and then you see issues with kidney. And so strep is not the only one that does this. In fact, other autoimmune disorders have been associated with infections through molecular mimicry. And you can see the list goes on. And so this is not new either. This is something that has been occurring and does occur. And so practically, when the antibodies attack our joints, we call it rheumatoid arthritis. When it attacks our pancreas or the insulin producing cells in the pancreas, we call it diabetes type 1. Or when it attacks the myelin sheath around the nerve cells, we call it multiple sclerosis. But what happens when it attacks parts of the brain? Unfortunately, sometimes we call it mental illness, bad parenting, rebellious kids, whatever. But really, it is a medical model that I described about pandas and pans, or it could be parts of what maybe have been diagnosed as autism or ADD or schizophrenia or bipolar, where the immune system is just attacking different parts of the brain. And we do know that the brain is the last frontier in medicine. So this is very important for us to continue to understand as we want to help chronic patients get well. So autoimmunity occurs when there's a breakdown of self and non-self, what we think of as friendly fire, which is not sure where that term came from, but anyway, it's also relevant to certain genetic factors like major histocompatibility complexes and SNPs from loci in the HLA class 1 and class 2, which is why you can often see a family history of autoimmune dysfunction in patients with immune-mediated neuropsychiatric disorders. About maybe 80% of the time, you can look at a family history and you can see where these patients have infection-triggered autoimmune condition that results in neuropsychiatric symptoms. You will see or find, or you can, in quite a majority of these families because of this self-non-self dysregulation. So in practical matters, molecular mimicry is just the inability to distinguish between two different things. And this, I don't know if it ever really would occur, but it's a good way of explaining what goes on. So let's move on to the case studies. So patients and their therapeutic categories and things that show clinical effectiveness in treating these immune-mediated disorders. So this one is about a 16-year-old girl who had severe OCD, tics, and then restricted food intake. Again, this could be confused with anorexia, but it's actually a fear of food contamination, a fear of choking, or other OCD-like symptoms. So this girl started her symptoms at age 11 with this food restriction, began having tics, choreiform movements, which is fine motor movements, difficulty concentrating, cognitive academic decline, urinary urgency does occur too, and dysgraphia, the inability to have fine motor control when you're drawing or writing. And unfortunately, this behavior got 6 calls to the police. So you can imagine the parents' dilemma here. We tested her, and she had 1 out of the 5 targets positive, and this is the result of testing. When 1 or more of the tests are abnormally high, that is a positive test for an immune-mediated disorder. So this was CAM kinase, and we'll talk a little bit about it later. This had a relapsing remitting process and increased when she had a strep exposure. So the previous diagnosis was varied, many of these with not otherwise specified conditions, autoimmune, post-infectious encephalitis, etc. But as we see with most of these cases, there's underlying infections, in this case, Lyme, mycoplasma, and Coxsackie virus. And so there was a family history of an autoimmune disorder and rheumatic fever, and even the siblings had pandas. So this patient was treated with plasmapheresis and IVIG with symptom improvement and even a small dose of Zoloft and Abilify. And then we tested her after this, and all her antibodies returned to baseline. So a young man, 17-year-old, who had multiple neuropsychiatric symptoms, Again, in this case, there was a sudden onset of OCD. You see the cognitive issues of concentration, the motor abnormalities, aggressiveness, and choreiform movements. And we tested him. He also had one positive, and many do have more than one positive, but this one had one positive. Relapsing, remitting, panic disorders, history of traumatic brain injury, encephalitis, etc. Again, multiple infections, Coxsackie virus, parvo, HHV6, Marfan's hypogammaglobulinemia, again, another immune system dysfunction, chronic sinusitis, frequent viral infections, again, rheumatic fever, which is autoimmune condition, OCD, autoimmune disorders in the family. And interesting, the patient responded to nonsteroidal anti-inflammatories, which actually reduces inflammation temporarily in the brain, and then multiple IVIG infusions with rapid improvement on these drugs. And again, his antibodies returned to normal. Let me share one more. We have hundreds of these. I won't go through a lot, other than another two. This is an 8-year-old young girl who again had numerous neuropsychiatric symptoms. These included OCD, which tends to be a hallmark, vocal tics, concentration, dysgraphia, and sleep disturbances, and the urgency for urination. Patient had positive for lysoganglioside, GM1, and tubulin, and again, relapsing remitting, diagnosed with anxiety, OCD, and an unspecified disorder of the immune mechanism. This one, they checked the strep titers, but there wasn't really anything that would indicate that the patient had strep infection, at least from the ASO or DNase-B, but strep can be identified in really any orifice of the body. And there was a significant history of 2 recent streptococcal infections with high fever, sore throat, sinus pain, cough, and a frequency of ear infections and idiopathic fevers. And then positive for mycoplasma, again, another infection. And then, of course, autoimmune disorders in the family, and then frequent bacterial and viral infections. This is when the patient was caught early. In these cases, before the immune system becomes producing, let's say, memory B cells, a patient was treated then with 1 course of azithromycin for the strep or for the bacterial infections and for mycoplasma. Rapid improvement in the symptoms. All of them were resolved. They returned to baseline after 2 days of treatment. And you can see here the patient's lysoganglioside and antitubulin autoantibodies returned to baseline. This was a published case study that was done by Dr. Bernstein, a 15-year-old girl who had been diagnosed with schizophrenia and unsuccessfully treated for psychosis and anxiety and depression in and out of treatment facilities, and they're preparing to put her back in. He sent us a blood specimen, and all 4 of her autoantibodies for dopamine D1, D2, lysoganglioside, and tubulin, their autoantibodies were elevated. And so what he did was put her on 1 course of plasmapheresis, and the patient had complete resolution of all of her psychotic OCD and anxiety. They weaned her off olanzapine, and within 2 weeks after plasmapheresis, she was back home playing tennis. And he said that the response has been sustained for over 6 months. We did read this report after it was published, asked him for a post-treatment blood sample. He sent it, and we processed it, and all of her antibodies were saw to return to normal. So what we really want to show is that we have hundreds of case stories of people like Grace, who was diagnosed with a mental disorder at 8. She was wanting to kill herself. The parents emptied their 401k twice with no answers, tested positive, was treated, and her mom sent us this picture recently of her back well on the cheer team and back to normal life. Adam, who was, when he was a young child, was diagnosed with ADHD. They thought he had autism, and they were going to put him back into an institution. But he was tested. He was positive. They treated him successfully. And recently, his mom sent us a picture of him running cross country, saying recovery is possible. He's 10,000 times better. So if you're interested, we can send you many published studies using the panel, looking at these autoantibodies and in different conditions. And then also some studies showing 58 case studies before and after treatment. So, and to summarize this, what we find is there's a very strong correlation. When an antibody is attacking the dopamine D1 receptor, we typically will see patients presenting with psychiatric clusters. So mood swings, depression, anxiety, even psychosis. When they present with antibodies attacking the dopamine D2 receptor, we typically will see these movement clusters. So they can be patients that might exhibit choreiform movements. They could be greater difficulty with sitting still, or could be diagnosed with ADHD or even possibly Parkinson's. When patients have autoantibodies against the lysoganglioside GM1, we typically see tic clusters associated with this, with complaints of joint connective tissue pain. We do have a high frequency in these patients of seeing tubulin and antibodies. Tubulin is highly concentrated in the brain. In fact, these are where the proteins are isolated from brain cells. And we see patients describing brain fog, OCD, difficulty concentrating, etc. And then lastly, this is actually a enzyme cell stimulatory assay in which we grow human brain cells in culture, not the patients, but a continuous cell line. And we incubate the serum on top of it. And if these antibodies stimulate the receptor on these human brain cells and stimulate the calmodulin CAM kinase, we identify this through a radio-labeled isotope. So why is that important? Because an antibody stimulating CAM kinase is responsible for the upregulation of the three neurotransmitters, dopamine, epinephrine, and norepinephrine. So antibody-mediated cell stimulatory activity shows a connection to a sympathetic nervous system activation. So patients will have symptoms of fight or flight behavior, separation anxiety, easily startled, mydriasis, etc. So these 5 targets are very helpful in identifying patients who may be suffering from an immune-mediated disorder that triggers these neuropsychiatric symptoms, and then they can be treated with appropriate underlying anti-inflammatory, immune modulator, anti-infectives. And as you can see, these patients become remarkably recovered. So let me summarize with some of the commonalities of patients. If you might have patients presenting, who would these patients be that might benefit from looking at whether or not they have these autoantibodies in this anti-neuronal antibodies in the autoimmune brain panel? We usually see that there's at least some treatment resistant to standard neuropsychiatric drugs, meaning they either get worse or they don't work, or they've been on multiple medications and nothing's changed, or they actually do worse. And that they have frequency of infections, as you've seen. They could have been diagnosed with neurologic Lyme or post-treatment Lyme disease. Many of the tick-borne diseases, as you saw, were on that list. And again, often you can see this family history of autoimmune disorders, not all the time, but most of the time. And then sometimes the rapidity of this, meaning sudden onset, meaning there was a normalcy and these changed, and then the patient changed, or it could be a gradual onset. Although gradual onset doesn't fit pandas pans, it still is, again, remember, a medical model. OCD, these restrictive eating disorders, if there's been a study that was looked at by Dr. Kindler and others, is looking at what maybe is the population of patients in these different clinics that are really suffering from an immune-mediated infection-triggered disorder, and it was quite high. Vocal or motor tics, anxiety, rage, depression, dilated pupils, about 30% of the patients will show that, and you can see these if they're constantly dilated or they're dilated for no reason. Relapsing remitting, which is also one of the syndromes we see, And one of the pediatric neurologists that we work with, who sees lots and lots of these patients, had said every single patient, if you ask them in a proper way, they will admit to having suicidal ideation. And we do know of unfortunate situations in which these patients have taken their own life prior to actually getting properly diagnosed or treated. So PANDAS and PANS obviously is one of the diagnosis or symptoms. So how do we wrap this up and say, what is really the treatment course? Well, first, you want to identify and treat all the infections because there's a stimulus to the immune system. Secondly, the immune system will trigger inflammatory processes. So often you'll see anti-inflammatories that will work. And you saw that one with even over-the-counter NSAIDs, which is not a long-term treatment, but it did indicate that this patient had an inflammatory condition. And then if the patients don't completely resolve, treat any immune dysregulation or immune dysfunction, and occasionally they may need symptomatic relief for many of the other complexities that occur as a result of metabolic dysregulation. But you also know that if you can summarize this, treat the infection, treat the inflammation, treat the immune dysfunction, but recognize that these different metabolic systems will affect other parts of the body. So you can see gut dysbiosis. When you treat these infections, you may see Herxheimer reactions. So it's always important to remember that you want to treat the entire patient, treat the patient, not the disease, so to speak, and that you might think of this as an autoimmune dysfunction can be the root of many chronic disorders. And of course, these diagnoses aren't 100% autoimmune, but there are parts of them, and this is why it's important to be able to have a precision medicine approach to get proper diagnosis and treatment. And this is what the autoimmune brain panel can do to help you in your clinic and your patients, where you can then separate them into what is the underlying root and how do you treat that. So let me end with this TAC law adapted by the late Dr. Sidney Baker. The TAC laws here are if you're sitting on a TAC, the treatment is not 2 Advil every 3 to 4 hours. Treatment for TAC sitting is TAC removal. And the take-home message is look for the root and treat the root cause rather than the symptoms. And then the second TAC law is if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms. Remembering that complex conditions are complex. So if you treat the immune system, but you don't treat the infection, you're still going to have this infection triggering the immune system again. So treat the condition, the complexity of the conditions as a complex disorder, but to be effective, you need to address all the underlying issues for complete resolution. So AONM, our partner here, Molecular Biosciences, can provide free consultative services to healthcare providers on the laboratory results. The website for AONM is there, and our website, there's their phone number. We also do have educational brochures and other information on the autoimmune brain panel and videos, publication resources on our website. And I'd like to thank you all for many of you are on the front line taking care of these patients. And as you know, they're very chronically ill. And yet it's always so great to see and hear that often we'll hear this is the first time that they've ever had been given hope that they will get well or get better. So thank you all for what you're doing. I'll pause there to answer any questions, and happy to have you here today listening.
Thank you so much, Professor Shimasaki. Fantastic. Just wonderful information, and always very, very encouraging to hear of all the work you're doing. Of course, America is about 26 or 27 years ahead of us. If you look at the studies that came out from, Professor Cunningham, Dr. Swedo, and so on, so long ago, really quarter of a century, but we are catching up here in the UK. through you, doctors associated with you, and now all the wonderful medical professionals here in the UK who are engaging with this, we are learning and have groups where we do meet from time to time and discuss cases. It's so, so important. Thank you, all your work. I do have one question that came in just beforehand, and I will ask that now. It is a slightly long one and a bit of a sort of personal case, but do say if you don't think it's appropriate. It's in regard to a 26-year-old, otherwise healthy male, perhaps on the very high-functioning autistic spectrum with ADHD. For several years, he's suffered from debilitating brain fog that lasts a few hours and is correlated with onset right after finishing a meal. He's modified his diet, essentially paleo type with organic vegetables and fruits. He has no known food allergies, but carbs seem to make it worse, and he's tried extensive elimination diet trials. Interestingly, he's received IVIG with a great response initially for several months, but then it stopped helping. Do you have any thoughts? And could there be a microbiome issue that needs to be addressed? This is a medical doctor asking this question about a patient of hers. So anything you can suggest would be helpful.
Yes, again, one of the complexities of these patients, and if we kind of take a look at it through maybe an immunological inflammatory lens, there could be a number of things. Certainly, the gut and the gut dysbiosis we see in patients who do have and present with these symptoms. So one thing often is to heal the gut, but it could be also possibly that the blood-brain barrier or the lining of the gut, which is you've heard the term leaky gut, leaky brain.
Yeah.
So the endothelial lining that lines the gut is similar proteins and similar cells that is the endothelial lining that lines the brain. So things that will heal the endothelial lining will also prevent this transfer of whether it's allergic proteins from food or autoantibodies into the brain, which could be why IVIG is doing something there. It's possible there could be an infection that's triggering that. It's also possible that although he said there's no, or he or she said there's no known allergies to foods, but maybe it's a gut lining and a endothelial lining issue that needs to be healed. And then that could, if that takes that care and shows improvement, that could be the direction to go. But again, thinking about it as what's working, then maybe deducing from it what might be causing that improvement. And so, although we don't know what IVIGs does completely, we do know, and again, this is important to know at what dose, whether it's a low dose or a high dose, but let's just take it for here for a moment. IVIG, as we do know, it does help to reset the maintenance of feedback inhibition for the production of antibodies in general, because your body will want to keep it in homeostasis, so it will downregulate the production of, let's say, all types of antibodies, including immune-mediated antibodies. So that's one of them. It could even be healing the lining in the gut, which then would be helping with the blood-brain barrier. So those are a few thoughts. Again, can't really diagnose the patient from that, but it sounds like there are some things that might give a hint of what could be going on.
You mentioned that very dramatic case where all of the antibodies, apart, I think, from the CAM kinase, were elevated. And then after just one treatment of plasmapheresis, the patient recovered and the antibodies were all down. How would the physician have known whether to prescribe plasmapheresis or, as in this case, IVIG? For us who don't have ability to really access that kind of treatment easily here in the UK, maybe you could just sort of pull them apart a little bit and explain.
Yeah. So again, plasmapheresis, is kind of a dialysis that removes all the antibodies. That's immediate. So you will see rapid, as you saw in that case, within 2 weeks, that patient was playing tennis and off of olanzapine. And so you're removing it. Now, remembering that the antibodies are most likely being produced and can be if it's long enough, with memory B cells that are plasma cells that are continuing to produce antibodies. Sometimes just the removing of that will stop and halt or slow down that production, which you'll see that immediate. IVIG tends to take longer, but you will start to see improvement because, again, we don't completely know all the impact of it, but it does help reset the immune system in this dysregulation. So in that case, how do they decide? Often plasmapheresis requires a PICC line, and it's a little bit more, invasive. So, and people have to know really where to go and what they're doing there, but it is very much more rapid. So you can look at a Lancet study, I think it was in 1977, showing the comparison of one IVI treatment compared to one course of plasmapheresis compared to placebos. They actually did this in children. And you can see they all had reductions in, I think it was their YBOC score, because they were suffering from some, again, immune-mediated neuropsychiatric disorders. So I hope that helps in some way.
My goodness, so long ago. Fantastic. Thank you. Well, we'll look up that study. I'll now go to this chat box because there is a lot in here. From Patricia, the question came in, would molecular mimicry be applicable with glycine and glyphosate? Dr. Seneff, who I'm sure you know from MIT, believes glyphosate hijacks our glycine molecule, which impacts our immune response, etc.
That's a great thought. We know that glyphosate causes a lot of issues when getting into the systemic system, and glyphosate, the structure includes glycine. So the body can mistakenly hold on to glyphosate as a glycine substitute. So it definitely could be. I'm not really up on those studies, but I believe that there is some understanding and indication that glyphosate can be a problem, especially when you look at it being able to do that as far as the body mistakenly hold it as a glycine substitute.
Yes. Suzanne asks, a major difficulty in the UK is that parents who've done research on PANS and PANDAS and read about IVIG are looking for a one-shot approach. They don't always want to address all the underlying factors. What can we say to such parents?
Yeah, this is important because you don't want to end up with a situation where it then becomes the medical community says, oh, we tried that didn't work. Remembering that this is a complex condition, so you do want to be sure that the protocol that's been chosen is one, long enough, or in the case of IVIG, generally what's been demonstrated is you need somewhere between 1 to 1.5 kilograms per body weight to do this versus the lower level. So I would say it's important to recognize the complex diseases need to treat complex conditions, multiple different potential issues. And that way you don't end up with maybe even making it more difficult in the medical system to be able to get further treatment, saying we tried that and that didn't work.
One thing I know that you have emphasized in your talk is to treat the infection if that's triggering the autoimmunity, and to try and eradicate that, or at least ameliorate it first. That's something that one can identify via the CAM kinase in some cases, isn't it? The fifth marker.
There is, although our CAM kinase seems to correlate with there being potentially another infection or a recurrent infection that hasn't been identified. It really is an assay to look at, is there an autoantibody that stimulates these brain cells to produce those neurotransmitters? But correlatively, we've seen that there tends to be an infection there. Now, you brought up another point about the infection. Again, this is treating complex conditions. Often there'll be a jump to go to, let's say, IVIG. The patient may improve for a little while, but they regress and they get worse. And they continue to do that over and over again. One possibility could be that the underlying root infections have not been identified or treated. And then therefore you're getting symptomatic relief temporarily from the antibody load, but then you're not dealing with the other part of it that's triggering or re-stimulating these antibodies. And therefore you might be in a cycle of continuing to do that. Now, on the other side of it, often, sometimes it does require many dosages of it over a period of time in order to get the immune system reset. So you do want to think about if it's resistant, then you want to be able to think, is there an infection that you're missing, or is there some other stimulus of the antibodies versus just trying to deal with the production of those antibodies?
Thank you. And Kurt asks, please could you comment on cases in adults with the same type of presentation? How
Yes.
successful have the physicians that you work with been with adults?
Yeah. So we initially started as an outgrowth because of the study with Dr. Cunningham, Dr. Sweeto in children. And children grow up to be adults, but they can't be diagnosed with pandas or PANS. And we have seen adult onset or gradual onset. Half of our patients and samples that come in now are adults because they're recognizing that this could be an underlying disorder. Now, the challenge is adults are really good at hiding these things or coping with these mechanisms in trying to alleviate that, but they do know that there's still something that's not correctly addressed. For instance, one adult that came to us, I think they were in their 50s or 60s and was tested and treated and got well. And she said, I've never known what it felt like to be normal. This is the first time that I really understood what normal was. So it is a little more challenging with adults. We do find that the test will pick them up also. That is one thing that we're also working on, looking at more adult normal controls. But if they do have highly elevated antibodies and it correlates with symptoms, we typically find that they will be responsive to similar medications.
Thank you. Lynn asks, how do we organize the test? Lynn, please just write to info, that's info@aonm.org. We'll put that into the chat. That's for the UK. And there is a special kit that is called a nano cool box that keeps the sample that you draw at exactly the right temperature all the way to the States. It does need to be analyzed in Oklahoma, in the States where the lab is. They are unique. They're the only lab in the world that does this test, and it is only there. So we need to make sure it's kept at the right temperature. It is a very specific tube. You do need to use the vials that are sent in the kit, and it does need to be centrifuged. So all of that is explained by the Academy of Nutritional Medicine in the UK. So no problem at all. We'll sort all of that out for you, as well as the transport. I don't really want to go into the costs right now because we have people from all over the world, including the States and India and so on, listening. And the costs do vary across the world. If you're in the US or Canada or Mexico or any countries near to the US, then obviously it's best to reach out to Moleculera direct. But otherwise, the Academy of Nutritional Medicine is responsible for the UK and beyond. So we're very, very happy to help out with shipments from Europe and beyond. So do please contact us. And Martin, perhaps you could put our details into the chat. The recoveries using non-drug immune modulators, antimicrobials, etc., are also seen, obviously, Professor Shimasaki. There are many health professionals who don't work with IVIG, plasmapheresis, antibiotics, and so on, and are very successful as well. I know that you work with many of them, don't you?
Yes,
Suzanne?
and again, if you remember those categories, anti-infectives, immune modulators, and anti-inflammatory agents, many let's say, FDA cleared medications or I should say therapies or treatments or that can fall into those conditions. Now, the difficulty is knowing which ones and which ones actually are just hype and which ones actually do work. But you have had on your program multiple practicing clinicians who are very well versed at doing that. And I will mention that a majority of medications have been derivatives of over time, maybe at least a quarter to a half of natural products. So even aspirin, acetylsalicylic acid from the willow bark, digitalis from the foxglove, opioids, all the opium, poppy, all of the narcotics, and your list goes on. So there are those that are out there, find individuals who do use them, and we've seen them quite effective too. And as I mentioned, you have those individuals sometimes presenting on your webinars.
Absolutely. We've had Dr. Nancy O'Hara, for example, speaking, Dr. Jody Dashaw, and many others as well. Please do look at PANS Pandas on our website, and then webinars, and all the webinars are there. Another question here is, my daughter has panda symptoms, but despite the strep infection, sorry, it's covered up by a pop-up that's just appeared. Despite the strep infection being historic, likely 5 years ago, the neurologist wouldn't treat it. What do we do? She's now 17, now diagnosed with ASD, but at age 12, she's begun the sudden onset of symptoms, including restrictive food intake.
This is the unfortunate case, as you saw that cycle that I showed of a typical patient that we encounter. I would say the important thing is to look for another clinician who understands and is willing to treat and believes that it's not all in her head or anything like that, because otherwise you're going to be trying to fight a battle that you probably won't win. And therefore, you'll be spending a lot of time, precious time, that you could be working with someone who understands or is willing to try things that could help. And this is actually how we do see these recoveries. Unfortunately, it needs to be the first, it needs to be with the first visit. But I hope in the future that we will get there. But in this case, for a child, it's the parents who are the ones who are the unsung heroes of doing this, and they need to be perseverant, and they are. But you do need to continue to find someone who will listen and is more understanding of the condition, and they're out there. And there are places that maybe Julian can direct them to that have parent groups that, whether it's in the UK or the US, there is parent groups who do know which ones are helpful.
Yes, do contact us on the email or at the telephone number that Martin has put into the chat, please, and we can give you some pointers on who to possibly contact. Many doctors now and professionals in the States will also help via Zoom too. So, but we do have providers in the UK as well, both medical doctors and naturopaths, nutritional therapists, and herbalists and others. So please do reach out. And there are also wonderful charities. There's the PANS Pandas charity here in the UK. There are lists out there, so we can suggest possible options. Another question is whether pain syndromes, chronic pain syndromes, can be a part of this condition.
Yes, chronic pain that's not resolved by, let's say, standard medications can be. You can think of fibromyalgia, which is an autoimmune condition that results in pain. It is one of those symptoms that does show up because inflammation and chronic pain are intertwined with the immune system. And we do know that there is immune system activation. And these inflammatory mediators like cytokines and prostaglandins can influence the immune system, or the pain receptors rather, So there is a connection between the immune system and that. If the patient is not responding to those standard medications typically used with pain and but I do believe that it is one of those symptoms that does frequently show up in
Yeah.
ADHD-mediated cases. So it is one of those areas that if you treat the immune system and you get that under control, often you may see a resolution to that also.
Thank you. I'll just ask one more question because I hadn't realized how late it is. I'm sorry, I'm mindful of your time and everyone else's, but I know we'll have you back and I'll mention another opportunity to speak to you in a moment. So in your estimation, what percentage of people with psychiatric conditions will be autoimmune related, would you say? And I'll just ask the second part of the question. If psychiatric drugs are not helping, would testing be automatically advised with the brain immune panel?
There are studies and publications showing that depending on the diagnosis, there can be anywhere from 30 to 60% of those patients. So for instance, obviously PANDAS and PANS is 100%. And if you look at autism, you can see that maybe anywhere from, if you look at the literature, there's an immune component to 60 to 70% of that. Now, whether it's autoimmune antibodies, that's another thing. Let's say ADHD and those, maybe you can see 50%. So it varies with the condition, but it is a very high percentage. And it's one that you would not want to omit or dismiss if a patient is not responding to standard medication. So the other question is, would you recommend testing if the patient is treatment resistant and or gets worse on psychiatric medications when they should be improving? It is one of those situations where before going on to lots and long-term other therapy, you might want to consider testing to see if it could be an autoimmune component. And we have many psychiatrists who are doing that because they see these same patients come back over and over and keep changing medications and they don't see any improvement.
Right. Thank you very, very much. That's a very high percentage, isn't it? Well, thank you so much. This was a fantastic talk, very, very informative, and we've got lots of, thanks here in the chat. I just wanted to mention that Professor Shimasaki will actually be coming over to the UK on the 20th of June. That's in less than a month. He'll be speaking at the Integrative and Personalized Medicine Congress, or the Summit, in Westminster. It's at the Queen Elizabeth II Centre, which is just opposite the Houses of Parliament. And that's a really fantastic summit that goes on from the 19th to the 21st of June. And it's been going on for several years now. It's the biggest in the UK. There's about 2,000 visitors a day. And we have a free pass for anybody who'd like to attend the workshops and the exhibition area. That's, I've put it in the chat, I'll put it in again, exhib-free. And I've put the link to the Congress in there as well. And if you'd like to attend the podium presentations, and you can attend them either just for one day or for all 3 days or only 2 days, we have a discount code which gets them at 20% off those tickets, EXH-20. So just contact us, contact AONM if all of that has sort of gone too fast and the note in the chat has already disappeared. The talk that Professor Shimasaki is giving is called Understanding the Connection Between Infections, the Immune System, and the Brain. Can infection trigger neuropsychiatric symptoms, and how can you know? And so he'll be speaking on the 20th. That's called Mental Health Day at 12:15. And we have a stand there. It's called B3. And it's right at the entrance when you come into the Congress. So do come to the stand, say hello to us. And if you're interested in meeting Professor Shimasaki, who will be over for 4 days, then just let us know and we'll arrange, a personal meeting with him or a meeting by Zoom. So sorry to have overrun a little bit, Professor Shimasaki, when I know you're under such pressure all the time, but it was wonderful to have you there. And thank you so much, everybody who was attending today, and everyone on the replay too. So look forward to seeing you in just a couple of weeks.
Yes, thank you, Julian.
Thank you.
Thank you for all that AONM is doing, and we'll look forward to seeing you in London.
Thank you. Bye-bye.